Welcome to this session. We are going to deal with the basics of chemical injury management here. We have all our speakers here, Dr. Devyani, Dr. Bhaskar Srinivasan, Dr. Mahesh. Dr. Ruchika unfortunately could not attend this session, so her talk will be combined with that of Dr. Bhaskar's. Without much ado, let me move on to my first speaker, Dr. Devyani. Do you want to start with classification and prognostication?
Yes. Hi, I'm Dr. Devyani. I'm a cornea and refractive surgeon at Gadri Eye Care Center. While I share my screen, I thought I'll just give my short introduction. I hope you're able to see my screen.
Yes, we
Yeah.
can.
Okay. So without further ado, assessing and classifying chemical injury, acute chemical injury, how do we prognosticate? We all know that we require a lot of multiple surgeries may be required in cases of acute chemical injuries in both the acute and chronic stages. Hence, the importance of prognosticating these cases for your patients. Your patients deserve to know what is lying ahead, and hence you should be able to reliably tell them what lies ahead for them. So we will be going through the following points. I hope to give you a toolkit to assess, and subsequently the speakers will give you tips to manage these acute chemical injuries of the eye. We want to clear-cut define these goals of treatment in a very clear way. There is an importance of reassessment. Don't consider that if something starts as a certain grade, it will end up as a certain grade, and therefore completely reassess your patient's staging every time the patient presents to you. Know your classifications, know what they bring to the table as well as what they don't, and know your offending agents and why does that matter to us. How do we assess our patients on the basis of these agents is something that I would like to cover in the next 12 minutes or so. First things first, even before your assessment begins, first aid is essential. We are physicians at heart, so we have to give first aid to our patients, and thorough eye wash is essential. My subsequent colleagues will be talking about this in further detail, but I felt that it required a mention before we start the assessment. And pH has to be checked before and after the wash. You get these pH strips freely available on Amazon or elsewhere, and you can keep them in the OPD. They don't really cost much, but they will give you a lot of information when you're dealing with these patients. Any and all inciting agents have to be removed. As part of the assessment, I would like to take a moment to talk about the proper history taking, because many of these incidents may be accidental, some may be unfortunately some may be part of vitriolage, and therefore a proper correct objective history is quite difficult to elicit in these cases, because patients are themselves extremely they're extremely distressed, and so are the relatives. So keep taking the history again and again, because patients may not realize that something is important, but to make your assessment, don't rely too much on the history, rely on what you're seeing in the eye, because that is what is the most reliable thing to take away. I think this one picture will tell us what we don't want to end up with, and this is the entire premise of my presentation today. I would like that all of us prevent this situation from happening. A large corneal perforation in a patient with a firecracker or a thermal injury, really bad prognosis from here on forwards, and therefore the one thing you want to avoid at all costs is a corneal perforation. And all my assessment details are going to be with this goal in mind, that we should not end up with these patients in our clinics, and at least we should do whatever is required in order to avoid that. Let's start with the Ropahol classification. Came way back in 1965, and whatever it talks about, it still holds true in certain senses. However, there are lacunae. It talks about the corneal epithelial damage, corneal haze, the visibility of AC structures, and depending on what the severity of corneal and limbal ischemia status is, it gives you a good, bad, or guarded prognosis. Having said that, the limbal ischemia that it defines as guarded and poor prognosis really has a wide range of presentation in between it. So something that is a limbal ischemia of half the limbus is involved versus something that is just above half, really it's difficult for you to say that one particular point will make make the prognosis very drastically different. Hence the need for a subsequent classification that came in 2001. DUA's classification also included the conjunctival involvement, which would give us an opportunity to actually give a more precise prognostic factor on the analog scale. And it involved it took the limbus involvement in account, it took the conjunctival epithelial defect in account, and therefore was able to give us a bit more information as far as prognostication of these patients is concerned. However, it does not include the tarsal surface at all. It only includes the bulbar surface of the conjunctiva, and that is something to keep in mind. Particularly, I feel these classifications are not meant to be a replacement of each other in any way. I think when you are actually assessing a patient of chemical injury, it is more appropriate to have both these classifications in mind, because each is giving you a pointer towards what you should be looking at. You should be looking at the corneal epithelial damage, you should be looking at limbal ischemia, you should be looking at the number of clock hours of limbus involved, you should be looking at how much of conjunctiva is involved. And even though it is kind of a really a detailed approach if you only look at all these things, having said that, there is a little bit of a lacuna that is still felt. As I mentioned before, the tarsal conjunctiva is not at all mentioned and not at all considered in the DUAS classification, while a tarsal conjunctival epithelial defect is more likely to lead to more complicated surgical procedures required in the chronic phase of the treatment. Hence, of course, that is not beyond the purview of the present talk, but its importance is hence elicited. So we know that we need more. Classifications should drive our thought processes. They should be able to tell us what we are not supposed to miss, and therefore the lacunae stand out even further. So these classifications did not mention adnexa and lid involvement, which specifically in the scenario of a vitriolage situation play very important roles in prognostication. And especially in the severely injured patients, these lid and adnexal involvements will further drive how many procedures the patient requires. I would like to mention the review article in Ocular Surface that was published by the Shankar group, and I believe that it gives us a real proper checklist of what all you should not miss, and in case of what situation, which are your options of management. So the I and E approach is really, I feel, important for us to not miss out on anything which is important in the future. So what is your I and what is your E? I is the inciting agent, the role of irrigation, inflammation control, an eye on ischemia and its management. A very neglected part of acute chemical injury management at times can be the IOP, and therefore you should have a lookout for either low or high IOP. What is the status of epithelial defect, and whether there is any exposure, which I believe also is one of the neglected parts of chemical injury management. I will leave the details of this management part of the paper to my colleague who will take care of the management, medical and surgical. But I believe that if you go through this one paper, you will actually find yourself with a proper checklist as to what needs to be done in the acute chemical injury management phase. A bit about the alkali acid difference as far as the uh, tissue response to each of these inciting agents is concerned. We all know that alkalis are much more dangerous because they cause cell death disruption and further penetration of the alkali, while the acids tend to coagulate and therefore create a barrier. However, in severe injuries with vitriolage in mind, I would say that this difference does not exist after a point. The load of inciting agent will actually decide how severe it is going to severely it is going to affect your eye. Having said that, alkalis tend to be powders. They tend to be non-liquid. Even if they are liquid, they tend to precipitate, and therefore they precipitate in the fornices. So if you know what your inciting agent is, you will also know where to look for them, and therefore you will be able to target your attention towards that area. An important part I feel in assessment is the role of fluorescein stain, and a word or two about it is essential because all your prognostication is going to arise from what you see in the eye, and what you see in the eye is going to be affected by the fluorescein staining and how well you do it. So this is a very clear-cut epithelial defect. You really don't need fluorescein or anything else to really tell you that, okay, this is a defect that is there and it's healing slowly, it's got an edematous cornea epithelium. But in a case like this, where you're barely able to photograph this child who is highly photophobic, who is non-cooperative, you are not really able to know whether this is an epithelialized surface or no. Fluorescein will actually tell you, okay, this is a completely denuded of epithelium cornea, but the conjunctival epithelium is trying to creep in. It's already 1 month since the injury, so you do expect that the corneal stromal necrosis will have set in, so you need to be a little more aggressive. A certain situation like this, where there is a global epithelial defect, is actually at times a little more difficult to assess because fluorescein by its very nature will stand out if there is enough contrast, and therefore if you don't have an edge of epithelial defect and the entire surface is denuded of epithelium, then assessing how much is affected might be a little difficult. So but having said that, if you have a surface with a global epithelial defect like this, then probably the first thing that should come to your mind is this will definitely require surgery. So, you know, if nothing else, then at least this should come to mind if something like this comes to your clinic. This, how clearly you can see that there are these charred epithelial edges are seen. This picture I included for two reasons. One, because I wanted to show that these convex edges of the epithelial defect show that there is a healing edge here. That, you know, this might not be as bad a prognosis as you may initially have felt. Having said that, also please bring your attention to the lower lid margin, because the fluorescein also has stained the lower lid epithelial defect. If it is a severe epithelial defect, or if it's a severe burn to the lids, then you are looking at more then you're looking at more number of procedures in the chronic phase, and therefore, you know, just to point it out, that you need to mention it in your notes and not forget the lids at all. uh, the goal of assessment at the end of it is management, and I hope I have done my job appropriately. So I pass my baton along to my colleague, Dr. Ramya, who will now take care of the medical management part of acute chemical injury management.
Thank you, Devyani. That was a very, very informative talk. I'm going to start sharing my screen now. Hello, everyone. I'm Dr. Ramya. I work in the Ravindran Center for Eye Care. And my talk here is the medical management in the acute phase, the first response. I have no financial disclosures. So you can have two spectrum of injuries present to you. You can have a wide range of first presentations, a very severe one to a mild one, but your goals of treatment will remain the same. You want faster epithelialization, you want to prevent a melt, you want to manage the intraocular pressure, and you want to control the inflammation. So I'm going to start with step one, as Dr. Devyani had mentioned. You want to start with irrigation even before you start with history taking. So you want to use what is readily available. You have a wide range of choices. You have normal saline, you have balanced salt solution, oral, buffered solutions, polyvalent amphoteric solutions like Previn. Amphoteric solutions, I want to mention a word about them. They are better. They are universally used in Europe because they neutralize the pH much faster, because they are hyperosmolar. They draw the water out of the corneal tissues and melt the debris quicker. And it has been proved through various studies there that if you use an amphoteric solution like Previn, you have lesser stromal inflammation and chances of ulceration. And to give you a perspective, you probably need 17 times the water to neutralize the pH that you do with an amphoteric solution. Tap water, because of its hypoosmolar nature, can cause corneal edema because of the hypertonicity. But as I said, the most important thing is to use what's available. So you don't want to delay the treatment looking for a better solution. Use lots, which means that you check pH every 15 minutes. If you don't have a pH strip, you will anyway continue irrigation for 30 minutes, and you're going to check for debris and remove the debris. Do not wait for a better solution. Anything goes. As a first response, even tap water goes. It doesn't matter if it is non-sterile or hypoosmolar or causes corneal edema. Using a solution earlier and more solution to neutralize the pH faster has shown better results than using a better solution. The difficulties with irrigation is going to be that children are going to be very uncooperative. So irrigate and then take them up for examination under general anesthesia. Most of these patients are going to be in severe pain, so they're going to have blepharospasm. Go ahead and use a topical anesthetic before you start the wash. Make sure that you have patients' face turns outwards, and start the wash nasally to the lateral side with the kidney tray held near the lateral side so you don't injure the other eye. Make sure you get the fornices, evert, double evert, and give a continuous flow. Ask the patient to look in all the directions. All of this will help you get every particle out. A Morgan lens is a lens that sort of looks like a Prose lens attached to an IV tubing, which allows continuous irrigation, but it doesn't get out the particles. So for lack of availability, choose what is available. The next step would be the assessment. So the history would come after the irrigation. At this point, you're going to put the patient on the slit lamp, assess the defect, the ischemia, the debris, measure whatever is possible, take photographs, draw diagrams. You would try to identify the offending agent. Children would need an exam under GA, like if you have a very severe case that needs surgery and you're not equipped for it, refer earlier than later. And severe blepharospasm will prevent you from doing the examination as required. But don't forget to look under the fornices, to look in each quadrant for any signs of ischemia or debris. A lot of this can be missed if you don't look for them. So the first and most important part of a medical management would be topical steroids. Prednisolone acetate or betamethasone can be used 4 times to hourly depending on the defect size. Use even if you have an epithelial defect. Use especially when you have an epithelial defect. You have a very narrow window to make this work. After 10 to 14 days, steroids can inhibit epithelialization and collagen synthesis. You can't stop them sometimes, but you may want to switch to a gestational steroid, or you may want to decrease the dose. So the first week is when it helps decrease the inflammation and aid in epithelialization. If you're scared of suprarenal infection, you can use a BCL if it's just a corneal defect. You can use adjuvant antibiotics, but do not wait for the epithelial defect to heal before starting steroids, because steroids reduce the inflammation, which is critical for the injury. And this is the most important medication in the acute phase. If paradoxically, instead of getting a raised IOP, which you would expect in the face of this kind of inflammation and trabeculitis, you actually get a hypotony, then expect the ciliary epithelium to have been involved, and you may want to start systemic steroids at this point. The eternal debate between acids and alkalis, I completely agree with my colleague. While we know alkali injuries are worse, the force and severity of the original injury plays a big role in assessing how severe the damage is. In terms of alkali injury, the commonest patient that we're going to have is a child. And any child, no matter how simple the injury looks and no matter how well you've thought you've examined, they're going to be uncooperative. And the rule of the thumb is you take them for an exam under general anesthesia, because most of them present to us with Lyme injuries, and these Chuna injuries are quite dangerous because every Lyme debris that's left behind is continuously secreting the chemical and destroying the eye as we speak. So you want to take them up for an examination with general anesthesia as soon as possible and get every bit of the debris out. You're going to have to evert, you're going to have to double evert, use a cotton bud, use a forceps, use whatever you need to get out the debris. Because if you have a large epithelial defect with a calcium plaque that's difficult to remove and you put an amniotic membrane on top of it, it's not going to do you any good because the chemical is constantly secreting on that, and no amount of amniotic membrane is going to help. If you find it difficult to remove, you can use an EDTA solution to chelate the chemical, but make sure that you get every last bit out. This is a very crucial first step. Even though it would technically come under surgical management, I thought I should mention it here. So the next group of drugs I want to talk about is the tetracyclines. We normally like to use doxycycline 100 milligrams OD or PT. They restrict the gene expression of neutrophil collagenase and epithelial gelatinase, which suppresses the alpha-1 antitrypsin degradation, and thereby reducing the ocular surface inflammation by inhibiting the matrix metalloproteases. This matrix metalloproteases degrade type 1 collagen, so you basically use it to stop the collagenolisis. We've only proved this in animal models, but a lot of the drugs that we use for chemical injury today are proved only in animal models for sheer lack of human studies. So it's cheap, it's safe, so we go ahead and use it. Avoid use in children and pregnant women. The next drug I want to talk about is ascorbate and citrate. We proved that in animal models, again, decreased levels of ascorbate were found in the aqueous humor, which led to decreased collagen synthesis. So we believe that ascorbate helps repair of tissue and reduces the ulceration and perforation rates. It's a 10% topical ascorbate that you can give every 2 hours. A topical citrate also has an additive effect, but the truth is there are difficulties here. These drugs need to be compounded. They are hard to find and they are quite expensive. So considering that the benefits are only in experimental models, normally people prefer to give an oral vitamin C 1 gram twice daily. It's an easier alternative. Just make sure you check your patient for any renal malfunctions because vitamin C is excreted by the kidneys. A very important step here is to manage the intraocular pressure. You will probably have to rely on finger tension to check the intraocular pressure, but you need to monitor it quite carefully and start anti-glaucoma medications, both topical and systemic as needed. If there is hypertonic, consider adding oral steroids. The inflammation is bound to cause race IOP, so keep looking for it. Talking about supportive care, if you have only a corneal epithelial defect, it may help the patient if you use a bandage contact lens. We'd like to give antibiotics to prevent secondary infection. If there is no bandage contact lens, I prefer an antibiotic ointment. Artificial tears, preferably preservative-free, also help with faster reepithelialization. And many of these patients, especially with a slightly more severe injury, prefer cycloplegics to help alleviate the pain. And we, of course, have the biologics that are greatly touted these days because of the growth factors in them, platelet-rich plasma, umbilical cord serum, 20% autologous serum. They do help with fast epithelialization because of all the growth factors present, which is also the thought process behind placing an amnion on the eye. But the fact is these are not easily available. They also need compounding and they need a cold chain for their maintenance, which because they are protein-based and they can get infected easily. So it's on the patient to maintain them. So they're quite hard. At least I don't use them. So I want to present a flow chart to summarize what I've said so far. So if you have a patient present to the emergency with a chemical burn, your first step is to start the irrigation with balanced salt solution or normal saline or whatever you have. And after 15 minutes to 30 minutes, you want to check the pH and see if it's reverted back to something close to 7. If it has, then you can put the patient on the slit lamp, take his history, document everything, the defect, the ischemia, use diagrams, measure the clock hours, mark the location. If it has not reverted back to normal, you're going to check for debris, look under the fornices and remove everything and go back to step 1, which is continue the irrigation until the pH turns to normal. Suppose you have no ischemia with a very small or no defect, just punctate staining. You're going to put the patient on a 4 times daily topical prednisolone acetate with artificial tears and antibiotic eye ointment and review the patient. On the other hand, if you have a large defect with not much ischemia, you're going to start on topical prednisolone hourly. We know that it helps. Vitamin C 1 gram twice daily, a bandage contact lens if it's only a corneal defect, and a tab doxycycline 100 milligrams. If the pressure is high, you're going to put the patient on anti-glaucoma medications, antibiotic eye ointment, cycloplegic, and pain relief as needed. If you have large ischemic areas with a total defect or a very large conjunctival and corneal defect, or lid issues where you have an incomplete blink or exposure, You will do the medical management along with immediate surgery, and I will leave the surgical part to Dr. Bhaskar. If the person who's presented to you is a child, you will obviously avoid doxycycline. And the first step would be to take the patient for an exam under general anesthesia. So this is a sort of an algorithm that I could make out. These are my references. I would also like to thank my colleagues, Dr. Devyani and Dr. Mahesh, for very kindly lending me the video and a couple of pictures. Thank you. And that's it.
So I have a question. In case of a child, you said we should avoid doxycycline. So is there any role for the azithromycin? Have you any experience, or do you? What is your suggestion?
Honestly, I wouldn't know about that because I haven't heard of it.
I would then pose this question to BSN sir.
Yeah, there's no specific role because there's no literature on that. And more importantly, these are all supportive measures. In a child, when you're primarily looking at a Lyme burn, you probably are ending up more with surgical measures, and you have to get the epithelium on by whatever means. If you are able to get the epithelium on, then your melt reduces by itself.
Yeah, so I mean, that is then secondary, I think, the issue.
So thank you.
We
and
move on? Yeah.
Yes, over to BSN sir for his talk on surgical management.
Just a minute, I'll just share my slide. Is my slide visible?
Yes.
So we'll just go briefly through the surgical management in chemical burns. Both Devyani and Ramya have done a good job as far as the introduction part and the medical management is concerned. No financial interests. So like Devyani mentioned, you need to address the eyes and ears in an acute chemical injury, and the outcome of how you manage an acute injury actually results in a better outcome in a chronic phase. So if you have ischemia, you need to address that. If you have an epithelial defect, you need to address that. The inciting agent needs to be addressed specifically. Exposure needs to be addressed specifically. So if you look at this algorithm, it kind of gives you an idea how you would want to go about it. Yes, you have a chemical injury. You need to assess and classify it based on whatever classification you have at this point of time. DUAS is still the best, even though it has its lacunae. You will start irrigation like Dr. Ramya mentioned. So then you're looking at the epithelial defect part. I'll come to the next slide. So if there is ischemia, you're looking at whether it is localized or it is generalized. If it is localized, you would probably observe. If it is generalized, you would want to add on certain surgical measures like tenonplasty. For exposure, if it is mild, moderate, you might just want to do a tarsorrhaphy. If it is severe exposure, you might have to do a cut down, a sharp cut down, or a skin graft. Intraocular pressure, if it is low, needs to be put on systemic steroids. If it is high, needs to be managed medically with anti-glaucoma medication. As far as the epithelial defect is concerned, basically you need to know whether there's just the corneal epithelium which is damaged, or it's also the conjunctival epithelium, because you need some epithelium on the ocular surface. At the end of it, whether it is conjunctival epithelium or corneal epithelium, if there is a source of epithelium which covers the ocular surface, your cornea will not melt under it. So if you have a small corneal epithelial defect, a bandage lens would work. If you have a larger defect, or if the defect doesn't heal by 10 days, because by the 10th or the 11th day, the steroids can cause stromal melting. So you would, if by 10 days of chemical injury, you still have a defect on the surface, then you have to actually go ahead and do an amniotic membrane transplant. If you have both a corneal and a conjunctival defect, it depends on whether you have purely a bulbar defect or you have a combination of bulbar and tarsal. If it is bulbar, again, it depends on whether it is less than 50% or if it is more than 50% involved. If it is less than 50% involved, you might just go ahead with an amniotic membrane to the ocular surface. And if that fails, or if repeated amniotic fails, you might want to consider some other surgical measures. But if it is more than 50% of bulbar involvement, or it is bulbar and tarsal involvement, you might have to put a source of epithelium there, because that basically means your corneal epithelium is not there, your conjunctival epithelium is not there. So if there's no source of epithelium, it will take longer for the ocular surface to epithelialize, and that will mean that you will end up with a corneal perforation or a melt or a scarring, which you want to avoid. So in those cases, we've tried using alloslet. You can also use oral mucosa as a substrate or a cultivated mucosal sheet in the acute phase if there's a large conjunctival defect also. And in case you end up with stromal melt and scarring, you would want to use tissue adhesives, EMT or LK as a case-to-case basis. We'll come to the cases later. So this is a video which is similar to what Devyani also showed and Ramya also showed with respect to the Lyme particle. So for a child, you need to take the patient up under anesthesia, and it might be stuck up in the fornices, which you need to be able to remove. Again, the lime can actually precipitate into the sclera and into the cornea. And if these are lime plaques which are there in the acute phase, you need to remove it. In the chronic phase, sometimes you might see occasional lime plaques sitting, but the eye is quiet because it has got converted to calcium carbonate. In that situation, you don't have to go in and dig and remove the plaque. But in the acute stage with inflammation, it is still releasing the components and making the surface alkaline. You need to remove the bits. And this patient, once we removed the lime bit, settled significantly well. Again, if it's a large defect like the one on the left, a small defect like the one on the left, a bandage lens will work. But if it's a large defect, then you would probably look at amniotic or alloslet in severe cases. And we did publish our first results with alloslet in early management of acute severe grade 4 or worse Duas classification injuries with good outcomes. We then subsequently looked at comparing our previous results of using amniotic alone when we are using amniotic alone for these grade of injuries versus when we started using alloslet. And we found that there's a faster epithelialization of the ocular surface when you're doing an alloslet. There's a lesser need for subsequent surgeries. There is a lesser need for subsequent LKs or PKs in this group. There's also a lesser formation of symblepharon in these groups. And that ultimately results in a faster visual rehabilitation, which is important, especially in pediatric patients. So this is a patient who had a lime plaque, who had a total corneal and conjunctival epithelial defect. We went ahead, removed the lime plaque, put a patch of corneal tissue to address the staphyloma there, and combined it with an alloslet. Gradually, the alloslet failed, which is okay, but because by 6 months, we can always do an auto slit, and he's maintained 6/9 vision in his eye for the last 6 years. Another patient who already had 2 amniotics done elsewhere presented 1 month post chemical injury with a completely deepithelized surface with these large granulomas sitting. We excised the granuloma, did an alloslet, the surface epithelized in 2 weeks' time, and then subsequently we did an auto slit. This is another child where there is a bilateral injury at 1 month post chemical injury with an amniotic also. There is a delayed epithelium on the surface. And if you leave it like this, you know this is going to end up with a melt or a perforation. So we released it, did an alloslet in both the eyes. The surface epithelized. Yes, it's not as transparent as what you would like, but at least it is giving the child mobility sufficient enough for the child to move around by herself. Again, when you're looking at an epithelial defect, an eye which looks like this, which is grade 6 Duas, where there's a conjunctival and tarsal defect, and an eye which is looking like this, which also has a defect, is still not the same, because this doesn't have ischemia, whereas the eye on the right, where it is looking white, has significant scleral ischemia. And the prognosis of both these are not going to be the same, because if you have ischemia, you need to address the ischemia with tenonplasty. If it's a localized ischemia, you can just observe it. But if it is a generalized ischemia, you would need tenonplasty surgery. Tenonplasty was first described by Rime, and we now use it regularly when there is severe. So this video shows up how you do a tenonplasty. When you're cutting it, you can see that there's no blood which is coming, indicating the lack of vascularity. And you dissect and remove the tissues from the periphery, get it towards the limbus, secure it at the limbus, and then you drape the amniotic on the ocular surface. Here, since the tarsal surface was also deepithelized, we draped it on the lid. So we used the conformer to place the amniotic on the surface so that the rest of the amniotic kind of falls over the lids, and then you secured it to the lid. And to get a source of epithelium, we followed it with an alloslet. And this one eye became hypotonic and we lost it because of the severity of the injury. This was the other eye which we were able to salvage. And this patient actually regained about 6/18 vision for about a year, and then there was a gradual failure of the alloslet, in which case we redid a top-up alloslet. And this pannus peels off pretty easily without a major issue. And you can easily peel off the tissue, access it, and we did a modified slit where we stuck additional allogenic tissue only at that quadrant which was conjunctivalized as such. And he's maintaining 6/18 vision. This has been almost now 3 years post-op. Exposure is again something that needs to be addressed. If you have a very bad exposure, it can lead to perforation, and this lady needed multiple surgeries after that to get her to reasonable vision. And if this has significant SCHAR, then the SCHAR needs to be cut down, or you need to have tarsorrhaphy to make sure that the ocular surface is closed. Tectonic procedures in the acute stage, if you have in addition a perforation, this needs to be addressed. Now this patient had a perforation, the peripheral sclera is also ischemic, so you can't suture it. The cornea around is not very healthy for us to suture a patch graft. So we actually did a large lamellar patch graft along with a tenonplasty and an amniotic in the acute phase. That LK failed and we subsequently melted, and we subsequently had to do a PK, but at least we were able to salvage the globe, and subsequently the patient underwent a keratoprosthesis in that eye. Again, this patient also presented with the perforation along with the lid stuck to the globe. We did a PK along with the cultivated oral mucosal epithelial transplant to form the fornices. He retained he got back about 660 vision for a reasonable period of time, but then the comet failed. Subsequently, we did a keratolimbal allograft. Even that failed, and then we had to do a keratoprosthesis. But he's been maintaining 624 vision in that eye for the last 6 years. A patient who had a perforation like this with a chemical injury, we knew this patient might ultimately need keratoprosthesis, so we went ahead, excised the lens and did a large lamellar graft to act as a tectonic support to the globe and covered the eye with the conjunctival hooding. Subsequently, the patient underwent a mucous membrane grafting to the ocular surface and ultimately underwent a type 2 keratoprosthesis under the mucosa to get back about 624 vision in her only eye. Another patient in the acute stage who presents with a lid stuck to the globe with an area of impending perforation. We had to surgically take the patient up to excise the symblepharon and then tectonically salvage the globe. So you did a large LK. Since there's an area of perforation, we decided to put a small patch of tissue, stuck that with glue, and then put a large corneoscleral graft on top of it to act as a source of limbus as well as tectonic support to the eye per se. Again, when you're dealing with these eyes in the chronic phase and you have to plan for a stem cell transplant, you need to know what is the thickness of the cornea under the scar. So if you have an OCT, get an OCT done to measure the corneal thickness and get an OCT done to measure the Panus thickness. Because if the underlying cornea is thin, you might actually have to combine a large corneoscleral graft, which will take care of the limbus also. Subsequently, you can always do an autoslet in about a month or 2 months or 3 months whenever the allogenic limbus starts failing. So this patient had a unilateral injury who presented with, who had an amniotic in the acute phase, but you can see how severely the ocular surface is affected, wanted better cosmesis. We went ahead, released the symblepharon, did a alloslet. The surface was better formed. Patient was keen on vision, so we did an autoslet. The clarity improved further, and then we did an LK for the patient. So when you're doing an LK in a post-SLED eye, you might want to preserve whatever SLED bits or the area of the limbus that you did. So we did a limbal sparing thing where we're dissecting the tissue and reflecting the limbal tissue back and doing a large corneoscleral graft and then sticking the limbal tissue back onto the donor cornea as such. Again, another child who had a severe chemical injury with ankyloblepharon, multiple surgical reconstructions, ex vivo alloslet followed by DALC, maintaining some amount of vision in that eye. Another patient similarly who had a partial success with an ex vivo limbal stem cell transplant, then underwent a large corneoscleral graft along with conjunctival limbal autograft of 3 clock hours. He maintained useful vision for about 4 years, and then he developed a failed LK because of a stromal rejection. So if the LK fails because of a stromal rejection, it's not too bad because you can again go ahead and redo the LK. It peels off in that area pretty easily. And once you can now see that the area which is vascularized is the interface, the previous interface. You can go deeper, and the deeper interface is much clearer now. And you can actually, as we're closer to the DM, you can actually peel off the tissue much more easily. So doing a repeat LK is not difficult. You will get the plane pretty easily, but you might have to go deeper than that initial plane to get rid of the vascularization. Again, a patient who had a severe chemical burn, one eye only was salvageable, had underwent a keratolimbal allograft that failed, subsequently underwent a Boston keratoprosthesis. He had issues with the Boston keratoprosthesis where there was a melt of the donor cornea. So he had to have an LK. Again, that melted. So we had to do an LK again and then did a conjunctival hooding since a bandage lens was not being kept in place, and he developed a little bit of a conjunctival overgrowth on top of the optic, which we keep removing every 4 months by snipping off the conjunctiva. A patient with a severe chemical injury with an RD underwent a type 2 keratoprosthesis with a VR surgery, and it's now about 7 years. He's maintaining 618 vision in his only eye. Another patient with one eye chemical injury, other eye was already damaged because of the chemical injury. There's a tarsorrhaphy done by the primary surgeon. So when we opened up, there was a large staphyloma. So we addressed the staphyloma with a patch graft, then planned for a type 2 keratoprosthesis with AGV and vitrectomy, and he has maintained 6/6 vision for the last 4 years. Another patient who presented in the acute phase with a perforation and a melt of the cornea, underwent a PK, underwent a VR surgery because she also had an RD. We tried to do an ocular surface reconstruction with allogenic cells that failed. Subsequently, we draped the ocular surface with a mucosa and then did a type 2 keratoprosthesis under the mucosa. Just a couple more slides. So this patient presented with a bilateral injury where there was probably inconsistent PL, but the patient was very keen. So we went ahead, draped a mucosa on the ocular surface and subsequently did a type 2 Boston keratoprosthesis under the mucosa, and she got back 3/60 vision. Another patient who underwent an OKP after an acute chemical injury, which was a case of vitreolarge in this case. And this is the most challenging case that we had so far. Severe ocular surface and facial deformities with an RD, underwent PKVR surgery first, subsequently underwent a modified orokeratoprosthesis under the conjunctiva. And this is how she was at presentation, and this is how she is now, maintaining 660 vision, and she's teaching in a government school as such. So when you look at a unilateral limbal stem cell deficiency, you basically look at whether the surface is dry or keratinized. If it is keratinized, you're basically only looking at cosmetic indications. If it is moist, you look at whether the fornix is formed or fornix is not formed. If the fornix is formed, then you're going to look at whether the underlying the pannus, the cornea is thin or it is normal thickness. If the cornea is normal, then you're looking whether the cornea is clear or it is scarred. If it is clear, you can just do an autogenic slit. If it is scarred, you might have to combine the autogenic slit at some point with an LK or a PK. If it is thinned out, you will have to see whether the thinning is in the center or it is more diffuse. If it is in the center, you might have to combine an LK or a PK with an auto slit. And if it is diffuse, you might have to combine it with a large slit, either at the same sitting or subsequently. So you use this kind of an algorithm even for a bilateral, so where you're looking at always to say whether it's keratinized or it is moist. If it is moist, whether the fornix is formed or fornix is shallow. And in this case, because there is no source of limbus, you need to know whether the patient is going to be eligible for immunosuppression or not. If he's going to be eligible for immunosuppression, then you can do stem cell transplants. If he's not eligible for immunosuppression, you're probably going to go ahead with the keratoprosthesis. And if he's eligible for immunosuppression, then you plan just like how you do for a unilateral injury. Only thing, the source of limbus here is going to be either an allogenic cell or a live related cell or a keratolimbal allograft or a cultivated mucosal sheet as such. And when it is bilateral, surface is keratinized or dry, or surface reconstruction procedures have failed, then you're looking at keratoprosthesis. Again, if your fornix is reasonably formed, you might be able to do a type 1 keratoprosthesis. But if your fornix is not very well formed, you might have to come to do a type 2 keratoprosthesis like an OKP or a Boston type 2, or some of the modifications like a type 2 Boston keratoprosthesis under a mucosa as such. And we've explained that very well in our publication on surgical management of limbal stem cell deficiency, which is freely available on the net. So to conclude, desperate times need desperate measures. You might need to think outside the box in certain situations. Acute phase management significantly impacts the chronic phase outcome. And in a bilaterally blind patient, every effort needs to be made to preserve whatever little bit of vision that we can give to the patient. Acknowledge our patients and my colleague at SN. Thank you. Sorry.
Thank you, sir. That was an amazing talk. And you did not overshoot the time. I basically combined 2 talks and gave it to you. Devyani, do you have any questions?
Yeah, so I have this patient who we have done a PK. The photograph that I showed with a large corneal perforation, that patient has undergone a large corneal graft with allo slit in the acute phase. Is 6 months out of surgery now, and since the surgery, epithelialized surface, a small area of granuloma and symblefron superiorly. So do you suggest that we take care of the symblefron granuloma first and then go ahead with any repeat PK for vision purpose, or can it be combined? What is your experience with
If it's
this?
a focal granuloma, it can be combined, not an issue. But you have to basically take a call on how the surface is, what is the other eye status. If it is a unilateral injury and you have a source of limbus, then you can actually just do your auto slit first, and then take a call on how your underlying cornea is. If after the limbus gets better, I mean the anatomical and the functional aspect of the limbus gets better, some of the haze might reduce by itself of your graft. But if it is already because of endothelial rejection that your graft is already hazy, once your limbus gets, your epithelium gets addressed, then you can take a call on doing a central PK or a DSEC if you feel that the haze is not that much and your surface is better. So we've done 2 cases where we've done a allo slit, then we've done an auto slit, then we've done a DSEC, and they do, I mean, as long as your epithelium is intact, then you're treating it just like a normal failed graft, which will take a call on how you would want to go ahead with that. But if there is a symblefron, there is a granuloma, there was a focal shortage of conjunctiva there, you will need to address that first. But if it's a very small focal area, you can always combine it with an auto slit.
Yeah, so it looks like a small, it's not a very broad-based symbiophone.
But if at all you might want to put a conjunctival graft in that particular quadrant alone. If you want to do it with, the other option is to just excise the granuloma, give us tricot injection, and then take the patient up for surgery after about a month. The tricot and the excision of the granuloma itself will reduce your inflammation, so your intraop bleeding, everything will become much better.
Right. Thank you. So over to Ramya for the next talk.
The next speaker for today is Dr. Mahesh Sanpetkar. He is going to speak to us on a broad overview of thermal injuries. Over to you, Mahesh.
Thank you, Ramya. And thank you all speakers. All of you have explained chemical injury so well that I don't need to explain much in my talk. My talk is basically about the firecracker injury, and firecracker injury, it basically covers chemical injury along with burn injuries. So most of the things covered, so that has made my job quite easy. I don't have any final disclosures. So firecrackers, they are basically the class of explosive pyrotechnic devices which were invented by the Chinese. And Chinese, as we know, they invent most of the hazardous thing as like Corona. And India being the second most affected country in firecracker also and in Corona also. So ocular firecracker injuries, these injuries, if taken proper care, they are most preventable injuries. But if occurred, they can have a significant visual impairment. Mostly it affects the male ranging from the age 6 to 20 years, and along with the children and young adults, the innocent bystanders, they also get affected. The incidence of all the firecracker injuries is around 20% of all the ocular traumas. In India, the firecracker injuries are more common during the festival of Deepavali, where traditionally the firecrackers, they form an essential part of our celebration. So firecracker injuries are ocular emergencies and they require immediate and intensive evaluation and treatment. Responsible factors for the firecracker injuries are our negligent behavior and working in close vicinity with the firecrackers. So firecracker injury classification can be classified as per the Betz classification into open globe and closed globe injury. Closed globe injury, it includes contusion and lamellar lacerations, whereas the open globe injury, it includes laceration and rupture. The laceration can again be divided into penetrating injuries, intraocular foreign bodies, and perforating injuries. The presentation of firecracker injury is often varied. It can be from simple lid laceration, corneal abrasion to the globe rupture or intraocular foreign bodies. In lids and adnexa, we may get lid skin burns, abrasions, embedded foreign bodies, laceration, periocular hematomas, and orbital fractures. In conjunctiva, we may get epithelial defects, limbal ischemia, laceration, multiple conjunctival foreign bodies. In cornea, we may get a corneal epithelial defect, corneal haze, multiple intrastromal embedded corneal foreign bodies, corneal perforations, limbal ischemia, and corneoscleral tear with uveal tissue prolapse. In anterior chamber injuries, we may get hypema, traumatic cataract, and iridodialysis. For posterior chamber injuries, we may get a Berlin's edema, vitreous hemorrhage, retinal hemorrhages, retinal detachment, traumatic macular hole, and choroidal rupture. So now coming to the management part of these firecracker injuries. A firecracker injury, when the patient comes to you, you should always look for the systemic condition of the patient also. If associated with ocular trauma, he has any other systemic injuries which is making his systemic condition unstable, the patient should first be referred to the physician and surgeon whenever required, get the systemic condition stabilized, and then only manage for the ocular conditions. So ocular condition management, there are two parts, medical and surgical management. And the goal of the treatment is basically to remove the offending agent, to control the acute inflammatory reaction, to have good visual and anatomical outcome, and to prevent the complication. Coming to the medical management part, the first and most important thing is for removal of the inciting agents. In case if you are removing the inciting agent, always apply topical anesthetic drop, have a good copious irrigation. The preferred fluid is amphoteric buffered solution, but in cases of emergency, if you don't have a amphoteric buffered solution available with you, you can use even the tap water also. In cases after doing a preferred copious irrigation, there may be some particulate material over the ocular surface which you need to remove manually. Once I don't have any financial interest with the pictures shown over here, just for the sake of convenience, to promote the ocular surface healing, we should always use artificial tears as per the condition of the ocular surface. The frequency should be monitored. Placement of the BCL helps in easy epithelium regeneration. To control the inflammation, use of topical steroids as per the severity of the injury. To control the secondary bacterial infections, we need to use the broad spectrum antibiotics. For the pain management, to reduce the ciliary spasm, always use cycloplegic eye drops. Few patients may require oral analgesics also. Along with these preliminary treatment, the supportive measures can also be given with the use of ascorbate, tetracycline, collagenase inhibitor, and anti-glaucoma medications. All these medications in detail has already been covered by Dr. Ramya. So now coming to the surgical management, which has already been covered by BSN sir in very detail. So I will be just mentioning about the names of the procedure. In cornea, if you have an inciting agent in the stroma, then we need to remove it under general anesthesia. Amniotic membrane grafting in cases where there is a large and non-healing epithelial defect. If there is a corneal perforation which is less than 2 millimeter, we can seal it with a stenoacrylate glue. If it is more than 2 millimeter, we may need tectonic keratoplasty. In cases of corneal tear, we need to repair the corneal tear repair. We need to do the corneal tear repair. And in cases in future for ocular surface reconstruction, we need limbal stem cell transplantations. For conjunctival and scleral tear, repair is almost important. Amniotic membrane transplantation in cases of large conjunctival epithelial defect. Tenonplasty is required in case if there is a severe limbal ischemia. For anterior chamber, if the hyphema is full chamber and it's non-resolving, we need anti-chamber wash. Also, if there is irododialysis, repair of irododialysis is almost important. Associated traumatic cataract will need extraction of the cataract and IOL implantation depending on the situation. In cases of lids, if there is a tracheitic or misdirected dialysis, it should be piloted. Lid laceration should be addressed properly in the same setting. Lid reconstruction surgeries may be required if there is a lid tissue loss. For the management can be conservative or surgical depending upon the symptoms of the patients. In severe injuries where the eyeball is auto-eviscerated and there is a nil visual prognosis, we may need a evisceration in primary setting, but as far as possible, evisceration in the primary setting should be avoided. So posterior segment management, most of the time it is a surgical management. We need to remove the intraocular foreign bodies. Vitrectomy is required in cases of vitreous hemorrhages. If there is associated retinal detachment, traumatic macular holes, we may need to address these problems with the surgery. So appropriate triage management and coordinated treatment by ophthalmologist is critical in cases of these patients in order to ensure the best possible patient outcome. So prevention is always better than cure. To have a smiling faces and sparkling eyes. So always we should have a strict check on the quality of firecrackers. We should always promote the safe use of firecrackers via school and media, and there should strict enforcement of the existing legislation, health education, public awareness, which is required to prevent the ocular hazards of happening due to firecrackers. Thank you.
Thank you, Dr. Mahesh. That was a very elaborate, elaborate talk. We had planned about 12 minutes for discussion. So, Devyani, Mahesh.
If I could just add a couple of points.
Please.
So basically, since we do have time, so let's go across some of the questions that normally come across to us. You have a patient who comes with a chemical injury, you have done an amniotic graft once, the defect doesn't heal, what should you do? This is a very often asked question. Obviously, the aim of surgery is to get the epithelium on. So if one amniotic has not been successful, you would want to go ahead and do a repeat amniotic. You would want to consider doing a tarsorrhaphy to close the lids so that the epithelium heals under it. How does tarsorrhaphy work? Basically, it reduces the exposure to the ocular surface to the outside abrasive environment to a certain extent, and to a certain extent, the tarsal blood vessel also does give a little bit of oxygen. So there is some amount of healing which happens just by doing a tarsorrhaphy as compared to, say, just by putting a contact lens alone. Having said that, what we've realized is if you have a very large conjunctival defect, it is going to take longer for the ocular surface to epithelialize. If it is going to take longer for the ocular surface to epithelialize, the sequelae will be there with respect to corneal scarring, melting, perforation. The number of amniotics that you would have to do will be more. You will have to then end up pulling the lids and closing the lids together, which will lead to a fornical shortening. And if that happens, your subsequent chronic phase rehabilitation becomes a lot more challenging as such. So in between, we did try to take, we had heard Professor Dua say that he takes just a fresh conjunctiva from the other eye, a large graft, and sutures it as a free graft on the cornea to protect the cornea. And with that in mind, the only worry that we had is our patients, most of them are bilaterally affected, and sometimes they are not very keen to touch the uninvolved eye in the acute phase, and you have to take almost about a 13 millimeter conjunctiva from the healthy eye. So we did try to use mucosa as a sheet for the cornea. The idea was get an epithelium on the cornea, so even if the rest of the conjunctiva takes longer for it to heal, at least the cornea underlying the mucosa would not melt, would not scar. This was based on our experience of doing the OOKP, where the underlying cornea, even when we are reflecting the mucosa subsequently, looks absolutely pristine. We did that, but the mucosa was a little bit thicker. Also, the mucosa is a vascular structure, and when you're placing it in an avascular area like the cornea, it didn't take up. So out of 5 patients that we did, in 3 it took up in a patchy manner, in 2 it didn't take up, it got necrosed, probably also because the fact that these were eyes with significant tenon's ischemia. But this gave us an idea, and when SLET started, we thought this would be a good idea to use an allogenic source of epithelium to get the epithelium on the cornea. That is how we started off doing SLET in 2015. And our experience with allogenic SLET has been that it does epithelialize the surface faster. As long as the SLET bits stay on the eye, most of the eyes epithelialize in 2 weeks or 2 weeks to 3 weeks time. The eyes which don't epithelialize primarily have been those eyes where there has been an intracorneal line plaque, where the line plaque itself keeps, and you're removing it, but the surface is irregular and it takes longer, or in eyes where the SLET bits fall off. There are certain prerequisites for an allo SLET, which basically is the fact that you need to use tissues which are not too old. So we would prefer to use tissues which are within 48 hours of harvesting as such. The benefit of an allogenic cells is you are able to put a lot more of limbal tissue. See, when you're putting a stem cell in a hostile environment, you would expect the cells to get damaged by the inflammation itself. The advantage of a limbal tissue is you can put as much as you want, and it does epithelialize fast. Even if it fails subsequently, you do have the choice of doing an auto SLET at that point of time when the eye is quiet as such. It protects your cornea, because once the epithelium is on, the surface quietens immediately. The need for you to use steroids, everything significantly comes down. Post-operatively, we are not advocating using systemic immunosuppression, because the role of an allogenic SLET in the acute phase is just to epithelialize the surface. It is not, we are not aiming that it should last long, because we always have an autogenic SLET from the other eye, which we can always do subsequently in 6 months' time or 8 months' time. Unless it's a bilateral injury where we would put the patient on systemic immunosuppression as such. And in our first study, we did an imprint, we did give the cells after the allogenic SLET and did a genetic analysis, which showed that it contained both the donor and the recipient characteristics, indicating that there is definitely some amount of existence of the allogenic cells over the eye for the period of 6 months or so. And 6 to 8 months later, once the eye is quiet, you would always consider doing an autogenic SLET in a much more controlled environment. Your cornea is clear, so you're not worried about needing an LK. Your fornices are better formed, so your surface reconstruction becomes easier. And your success when you're combining a stem cell with any other surgery is much lesser as compared to just doing a SLET or a limbal stem cell transplant as a primary procedure. So you would want to avoid combining it with LK or PK as such. So this aids in all these three aspects. So idea is get the epithelium on ASAP. If the epithelium is on, epithelium protects the cornea, your problems become better. If after multiple times you are still not able to get the epithelium on for whatever reason, do a tarsorrhaphy, do a sinocular glue, do a complete closure of the eye, leave the eye. You can always do a keratoprosthesis later, but that is more if you're looking at a bilateral injury. If it's a unilateral injury, if you feel it is so bad that nothing is happening, you can just do a tarsorrhaphy and then subsequently just open it up and do a cosmetic contact lens fitting and fornices to be formed for a contact lens fitting subsequently.
Yeah, I've realized that not enough credit is given to the fact that deep fornices are such an important prognostic factor, especially when you're going to do SLET or any other corneal procedure for visual rehabilitation. Because if you have deep fornices, really half of your problems in the post-operative period are taken care of.
Inflammation is the most important thing in the post-operative period. So whether you do SLET, whether you do at any point, even if you do an auto SLET, you need to control the inflammation in the perioperative period. It's something similar. So if you're doing a symblepharon release or you're doing a pterygium or whatever, unless you are controlling the inflammation, it is going to recur. One of the factors to control inflammation is to have the epithelium on faster. That is why when you compare a autograft and pterygium versus a bare sclera, the recurrence rate is much higher in a bare sclera because the presence of the deepithelized sclera is an inciting agent which induces inflammation, and that subsequently leads to your recurrence of pterygium as such.
Yeah, true, absolutely. So, do we come to an end of this session, or do we have 4 more questions? Ramya, what do you think?
Any questions from the audience?
No, I checked the question and answer. We haven't gotten any open questions.
No open questions, yeah.
Questions. So we've actually finished ahead of time.
Right. I think we kind of reset the clock for AIOC to get back on time. They were running a bit behind. Our previous session helped a bit, and we've kind of made them ahead of time now. So, a few words from Ramya.
Thank you, everybody. Thank you for being here. Thank you for giving us this opportunity. This was a very nice session in the sense that it was interactive. And thank you, sir, especially for that the discussion in the end. I think we got a lot of pearls from that. And I think we can end this session now and hand it over to the next.
Thank you, AIOC. Thank you, everyone. Thank you, Thanks, Mahesh.